Hi, my name is Noah Drew, and we're back with you from the University of North Texas Health Science Center at Fort Worth. This is the second and final production of our virtual Meet Us at the Med event. In part one, we heard from our School of Public Health's Dr. Erica Thompson. Today, we are joined by one of her public health colleagues, Dr. Erica Spears. As an undergraduate, she earned her bachelor's degree in mass communication with an emphasis in public relations from Louisiana State University. She also holds a master's degree in speech communication with an emphasis in health communication from the University of Houston. Dr. Spears then went on to earn her doctorate in health education from the College of Education and Human Development at Texas A&M University. While at Texas A&M, she also completed an advanced research methods certification for social sciences. Dr. Spears' current research is focused on addressing health disparities observed in preventable chronic conditions within communities of color. The majority of her work focuses on health knowledge, health communication, and social constructs that may serve as barriers to health-promoting behaviors. Dr. Spears, we appreciate you joining us today.
Hi, I'm Erica Spears. I'm a health disparities researcher and educator here at the Health Science Center. It's my job to ask questions that I care about and to motivate the next generation of researchers and practitioners to think deeply about their role in promoting health for everyone in our community. I began my career in public health in 2007. My first position was in Houston, Texas as an adolescent health educator, working in HIV prevention. I went to high schools all over the city to deliver an HIV prevention program created by the city's health department. While the major message about safer sex practices was the same, the way the message was received was not. I quickly learned that what I said to these students didn't matter unless I could convince them that this information should matter to them. And what mattered to students in one high school mattered less to those I taught in another area of town. Their cultures and beliefs and access to resources all influenced whether or not they would listen to me. It was my job to figure out how to effectively reach these students and convince them that the prevention practices I worked to teach them were strategies that they could and should want to use. This public health experience deepened my understanding of the power of health communication. It highlighted the importance of not only effective message design, but some of the different layers that went into how those messages are received. Health communication theory and strategies are used heavily in my work today, and I also teach these principles in a health communication course to master's students at the Health Science Center. In 2011, I had the opportunity to return to my hometown, which is New Orleans, Louisiana, to work with the city's Healthy Start program. Healthy Start is an infant mortality reduction program, and unfortunately, New Orleans had one of the worst rates in the country at that time. Before joining Healthy Start, I didn't know much about the program. I assumed, like a lot of people, that it was designed to help low-income moms have access to resources, and that was part of what they did. However, our program was not restricted based on income. While open to all moms, our program actively recruited African American moms regardless of income or education. I know that seems odd. Normally, we think that things like income and education protect people, and while these things certainly help in many instances, it wasn't necessarily true for the African American moms we saw that lost their babies. On average, an African American mom with a college degree was more likely to have a miscarriage or lose a baby due to sudden infant death syndrome, or SIDS, than a Caucasian teenager with a high school diploma. Healthy Start received a grant from the Robert Wood Johnson Foundation to help us examine how stress associated with race factored into the maternal and child health disparities we saw in our program. We weren't looking at differences of skin color, but how that skin color plays out in society to affect things like where you live and how you're treated. Then how those things affect your mind and your body's ability to sustain life, not just for you, but for your children. This work inspired me and was ultimately the reason I returned to school to pursue my doctorate. I have since used my experiences as a practitioner, working with people at various levels of community to inform my research. My work considers how things like culture, stress, and environment influence health behaviors and ultimately health disparities. My goal is to use that understanding to design more effective interventions and improve health in minority populations. The first study I designed looked at type 2 diabetes knowledge in middle-class African Americans living in New Orleans, Louisiana. African Americans are 1.7 times more likely to develop type 2 diabetes than Caucasians. More than half of the residents of New Orleans are Black or African American. Additionally, there are structural issues in New Orleans that may negatively affect health for its residents. For example, parts of New Orleans have been deemed food deserts, which is a classification used to define areas that don't have enough access to healthy fresh foods to accommodate its residents. My study looked at things like how access to food options influence food choices for a more affluent population, one we don't typically think of as lacking resources. I also wanted to know what the group knew about type 2 diabetes. Again, while we don't normally look at the middle class and think of the need to educate, health knowledge is specific, and what people don't know has the potential to harm them. When looking at the grocery stores where my participants shopped, when healthy options were conveniently available, people were more likely to make use of them. This makes sense. Unfortunately, those healthy options were inconsistent and varied, not only in availability, but in quality as well. We also found that those options improved in neighborhoods that were more racially diverse. Neighborhoods that had higher rates of African Americans generally had less healthy food options. When looking at diabetes knowledge, there was a lot of misinformation about how diabetes was developed, which also meant there was misinformation about how to prevent the disease. This type of information can be critical to the success of an intervention designed to reduce rates of type 2 diabetes in African American communities. I have also had the opportunity to do similar work with different conditions. For example, I worked with a team at Auburn University to study the role of race-based stress on disease progression in African American women with SLE, which is a form of lupus. Women are more likely than men to develop SLE, and African American women are more likely to develop and die from lupus-related complications than Caucasian women. We don't have a clear understanding of why this disparity exists, however. There are a number of theories, and many of them are related to health behaviors. The one we investigated was smoking. We all know smoking is bad for us. It's particularly dangerous for someone with lupus. So why would someone with lupus smoke anyway? Our study looked at possible answers to that, and one theory we came up with was that smoking may be tied to race-based stress for the nearly 15% of women in our study who reported smoking. Studies have shown that experiences of discrimination are processed differently in the mind and in the body because they are connected to things that are often tied to a person's definitions of who they are. To be mistreated because of something you cannot control is a very difficult thing to handle. For women in our study, we found that stress tied to race, which in this study were concerns about judgment and possible unfair treatment based on race, was related to smoking and worse health outcomes for these women. Right now, I'm developing a study to look at protective factors that may influence survivorship in African American women with cancer. African American women are disproportionately impacted by certain forms of cancer, like triple-negative breast cancer. Survivorship is also less likely for African American women. So what I want to look at is how, despite the odds, these women survive, and what can we do to learn from them that may help us in other areas of health. While the conditions I research vary, the mission of all my work is the same. I want to better understand how and why health disparities persist and figure out ways to eliminate them. Both the problem and the solution are complex, with roots at every layer of our society. Right now, more than ever, as we've seen African Americans and other racial minorities disproportionately represented in our COVID-19 deaths, my work seems critical. The disparities we see in diabetes, lupus, cancer, asthma, etc., are similar to the disparate rates of minority deaths we see now as a result of the pandemic. Those deaths matter to me. Those people matter to me. They should matter to all of us, and they are why I do the work that I do.
Thank you for joining us. I hope you enjoyed hearing from our expert faculty members as they shared about their work. I assure you that the examples shared today are representative of the work being done across all 6 of our schools. I encourage you to sign up for future events at the URL below if you're interested in learning more about our institution and how we're creating solutions for a healthier community.